This is the recording for the final review for care of the patient with chronic conditions. The first concept we're going to talk about is elimination. Urinary catheters, it's a sterile procedure, or catheter insertion is a sterile procedure. We need to deflate the balloon prior to removal. If the catheter in any way becomes contaminated, you need to get a brand new catheter. If it slips into the vagina, when you're doing either a straight cath or an indwelling catheter on a female, you want to leave that catheter there, get a new catheter, and then reinsert. Of course, we're getting a new catheter because the initial catheter was contaminated, but we're leaving it in place because we don't want to put our new catheter in the same place where we put the first catheter. We want to know the appropriate reasons for urinary catheterization. Appropriate reasons are urinary retention, critical illness where hemodynamic monitoring is necessary, and surgery. Urinary continence is not a good reason for catheterization because it presents an unnecessary risk for infection. Some things to take into consideration when we are caring for a patient with an indwelling catheter. Let's say we're doing our eyes and nose, and we realize that our patient has taken in a large amount of fluid, whether it's orally or IV, but they have a very small urinary output. We're going to assess that patient, and the first thing we're going to do is look for occlusions. We want to start in the least invasive way and then go to the most invasive way. So the first least invasive way I'm going to look for occlusions is right there. My patient's right there. I'm going to look at the catheter line, the bag. I'm going to make sure nothing is clamped, nothing is kinked, the patient isn't on top of the catheter. Other times we might look for an occlusion is we might have to irrigate it if there's no kinks. If somebody has like a large input or intake of fluid or intake of IV fluids, but the small output and they do not have a catheter, the way I'm going to look for retention is getting a bladder scan to see if that bladder is retaining urine. Condom catheter. A space of 2.5 to 5 centimeters should be left between the tip of the penis and the end of the catheter. The space helps to prevent irritation of the tip of the penis and allows for full drainage of urine. Adhesive tape doesn't expand with the changes in the size of the penis and can possibly impair blood flow. And it's also painful to remove. Therefore, it should not be used to keep a condom catheter in place. No manipulation of the foreskin is required during the application of a condom catheter. A condom catheter is rolled smoothly over the length of the penis and not stretched along the length. Risk factors for UTI, women versus men. Women are at a higher risk for UTI compared with men. They have a shorter urethra and a shorter distance from the urethra to the anus. A shorter urethra increases the risk of infection because the distance bacteria has to travel into the bladder is shorter. Also, a shorter distance between the urethra and the anus increases a risk of fecal material and bacteria being introduced into the urethra. Men also produce an antibacterial substance within their prostatic secretions that also reduces their risk of infection. Prevention of UTI. Always use a sterile technique when placing a Foley catheter. Give appropriate, thorough peri-care. Assess equipment carefully to ensure that the system is closed. And intervene to prevent prolonged catheter use. Avoid stool contact with the catheter and the urethral meatus. Cleanse or clean from dirty to from clean to dirty. What we mean by that is if you are doing peri-care, you're going to clean, like with somebody with an indwelling catheter, you're going to start cleaning at the urinary meatus, and you're going to end with the anus. Bladder scans have eliminated the need for in and out catheterization, so they also contribute to a decreased risk of UTI. When we're teaching our patients to take care of themselves at home, we want to instruct women to wipe from front to back. Patients should avoid bubble baths, and keeping blood sugars within normal range decreases the risk of UTI. And you want to teach people to pee when they feel the need to urinate, because we want to empty bladders frequently and completely to decrease the risk of UTI. Our signs and symptoms of UTI: an elevated white blood cell count, urine with a pungent or a strong odor, increased sediment in the urine, confusion or altered mental status, a change in urinary pattern. What we mean by the change in urinary pattern is this person having more frequency with an inability to completely empty the bladder. Another sign of UTI is cloudy or dark urine. Long-term indwelling catheter. The client should take a shower rather than a bath because sitting in a tub allows for bacteria to easily access the urinary tract. The bag should be emptied regularly, not once a day, but at least 3 times a day. The drainage bag should be hung below the bladder. Adequate amounts of fluid should be consumed to help prevent sediment and infections. Pregnancy changes in elimination pattern. Larger volumes of urine, because the woman has more blood flow during gestation, and this can cause more frequent urination. As the fetus grows, it can place pressure on the bladder, causing frequent urination. The use of prenatal vitamins with iron can also contribute to constipation in pregnant females. TURP, transurethral resection of the prostate, most widely used procedure for prostatic gland removal. It's normal to see blood right after surgery. We will need to empty the drainage bag as needed, and we subtract the amount of irrigant infused from the total output to obtain the output and record. So what we mean by that is somebody who has a TURP is going to have a continuous bladder irrigation. So what that means is there is going to be like an irrigant, like normal saline, being flushed into the bladder and then coming out to keep that prostate gland from like clotting and all of that. So we have to let's say we had 1,000 out, but we know 800 went in as our irrigant. So we'd have 200 of output. Post-TURP, the client should be encouraged to incorporate fruit juice in his diet to help keep bowel movements regular and soft, as straining for bowel movements after surgery can cause increased pressure on the prostate area. The client may not drive for 2 weeks after surgery. The client is taught to avoid heavy lifting for 4 to 8 weeks after discharge. We want to advise the client to call the doctor for heavy bleeding, but minor bleeding when defecating, coughing, or exercising is normal. Iodine allergy versus shellfish allergy. People with a shellfish allergy will react to certain shellfish. Shellfish include marine creatures with shells, including crabs, shrimp, lobster, oysters, scallops, as well as squid and octopus. We want to use chlorhexidine as the antiseptic when inserting a Foley catheter instead of povidone iodine, just because people with shellfish allergies could possibly have a cross allergy to povidone iodine. Latex allergy. This is an allergic response that can lead to issues with skin integrity. We want to realize that there are certain cross allergies that are shown to have, or certain allergies that have a cross allergy with latex. These include bananas, avocados, kiwis, plums, peaches, cherries, apricots, figs, papayas, tomatoes, potatoes, and chestnuts. So people allergic to bananas, avocados, kiwis, plums, peaches, cherries, apricots, figs, papayas, tomatoes, potatoes, and chestnuts could possibly have a cross allergy with latex. So if we are aware that our client has an allergy to one of these things, we are going to remove all products containing latex from the room. This includes gloves, tourniquets, tape. And when it comes to elimination, something that we need to keep in mind with our patients who either have an allergy to latex or are allergic to something that could present with a cross allergy is when we're inserting a Foley catheter, we need to be aware that, hey, is this Foley catheter made of latex? No, if it is, we need to swap it out for something else, like maybe a silicone Foley catheter. So just looking back at those two, if my patient has a shellfish or an iodine allergy, I'm not going to use the povidone iodine that commonly comes in a Foley catheter kit. If my patient has a latex allergy, I am not, or something that could be a cross allergy with a latex allergy, I am not going to use a latex indwelling or straight catheter if that person has an order for a Foley catheter. Activities to promote bladder health. We want to ensure that our patient is adequately hydrated. We want to encourage them to empty their bladder with the first urge and empty it completely. Maintain a normal body mass index. Refrain from smoking. Minimize caffeinated beverages. And have regular patterns of elimination. Clean catch urine sample. Male. They're going to have to retract the foreskin slightly to expose the urethra. Do not pull the foreskin over the meatus because that foreskin could contaminate that urinary meatus and contaminate your sample. The person is going to use a circular motion to clean the meatus, and they want to use a new towelette for each wipe, and then discard the old towelette. They will void a small amount prior to collecting the sample, so they are collecting the sample midstream. When it comes to cleansing, like a female for indwelling catheter, we want to remember that we're cleaning from top to bottom, from outside to inside. So the way that that's described is anterior, posterior, from lateral to medial. So again, we're cleaning anterior, posterior, so from front to bottom, from lateral to medial, from outside to inside. Collecting a CBG, we use the sides of the finger. It's a little bit less painful because most of your nerve endings are on the tip of the finger. And if somebody with diabetes in the future, unfortunately, developed diabetic retinopathy, they are going to need the pads of their finger to possibly learn how to read Braille. When we're collecting a CBG, we run into difficulties, we can do things as a nurse to promote blood flow, making the sample easier to obtain. Things like this include is dangling the hand. So it promotes blood flow flowing into the fingers. Another thing that we can do is get a warm washcloth and put it on the finger. This promotes vasodilation and promotes blood flow to that finger. After we collect the sample, we're going to follow the patient's sliding scale to determine how much insulin they require if they have a sliding scale. Collecting a wound culture. Collection from the crusty area outside the wound may be colonized with microorganisms that haven't affected the wound, and they're going to show an inaccurate result. Using an antiseptic solution before collecting the specimen will remove any bacteria that are in the wound from the possible sample. And the wound should be cleansed with normal saline or sterile water to remove flora prior to collecting the specimen for wound culture. Rotate a sterile swab in the center of the wound base. Decreasing constipation while taking iron. Whether this is iron that a woman is taking during pregnancy as part of her prenatal vitamin, or it's just somebody taking iron because they're anemic, and they develop constipation, we don't want to immediately tell them, hey, quit taking your iron supplement. We're going to try non-pharmacologic methods to decrease that constipation. And these things include physical activity, increased fluid intake, and increased dietary fiber. Other than iron, other causes of constipation include poor diet, poor fluid intake, and immobility. Collection of a stool specimen for fecal occult blood testing. Obtain specimens from 3 different stools. Fat intake will not affect the results of the testing. The specimen cards do not need to be refrigerated. Increase water and fiber intake in the days before. Increase water and fiber intake for a few days prior to testing is going to facilitate the collection of multiple stools. Vitamin C, red meat, poultry, seafood, some raw vegetables can cause false positives in fecal occult blood testing. Types of incontinence. So the easiest thing for you guys to do, or it's an idea, is possibly go to your elimination PowerPoint and copy and paste the table. But I'm just going to go over the table really briefly. Types of incontinence: stress incontinence, leakage of a small amount of urine during physical movement, coughing, sneezing, exercising. Urge: leakage of a large amount of urine that is at unexpected times, like during sleep. Overactive bladder: urinary frequency and urgency, with or without urge incontinence. Functional: untimely urination because of physical disability, external obstacles, or cognitive problems that prevent a person from reaching the toilet. The example that we've used in the past with this one is you have a patient who cannot physically get to the toilet. They turn on their call light. We don't get to them in time, whether it's the nurse or the CNA or whoever. For some reason, we didn't get to the patient in time, and they have an episode of incontinence because they couldn't physically get to the toilet. That's going to be functional incontinence. Overflow: unexpected leakage of small amounts of urine because of a full bladder. Mixed: usually occurrence of stress and urge incontinence together. Transient: leakage that occurs temporarily because of a situation that will pass. Infection, taking new medications, cold, with coughing. As the body ages, there are anatomic changes that increase the risk for urinary incontinence. However, this is not a normal part of aging. It is appropriate for the nurse to gather more information about the patient's incontinence, but it's beyond our scope of practice ever to recommend surgery or anything of that sort. That's just beyond our scope of practice. Autonomic dysreflexia is a syndrome affecting patients with spinal cord injuries above the thoracic level. A stimulus from the autonomic nervous system causes hypertension, bradycardia, severe headaches, pallor below the level of the injury, flushing above the level of the injury, convulsions, stroke, and death. The most common causes are constipation and full bladders, which can be caused by clamped urinary catheters. The primary treatment for this condition is removal of the stimulus. Some medications are also prescribed to stabilize patients who have severe cases of autonomic dysreflexia. So that being said, like constipation and a full bladder could be a cause of autonomic dysreflexia, and the best way to treat this is to remove that stimulus to get rid of all these symptoms. So if the person's bladder is full, let's think about it. Let's say we have a patient with a thoracic injury and they're exhibiting signs and they have an indwelling Foley catheter. The easiest and simplest thing I could do to ensure that the least invasive, again, is to look at the tubing on my Foley catheter. Is any of it clamped? Is the clamp on? Is the tubing folded? Is it pinched? Is there something that's obstructing that flow from the urine from the bladder into that bag? Is it something that simple to fix to help them empty the bladder? Let's say they don't have an indwelling catheter, but I want to just see, is their bladder full? I can do a bladder scan to see if that person's bladder is full. If they don't have a Foley and they do have a full bladder, and they're exhibiting these symptoms, I have that information. I have all my vital signs. I know that they have a full bladder. They don't have a catheter. I can ask the doctor for a catheter in an attempt to remove that stimulus. Another thing that I can assess as a nurse, if I am suspecting autonomic dysreflexia, if the bladder is not full, if I've determined the bladder is not full, I'm going to look at the bowel record just to make sure that my patient isn't constipated. If it's been several days since they've had a bowel movement, I'm going to look at their orders to see if they have anything for constipation, whether it's a suppository or whatever possible orders they do have. If they do not have orders for something for constipation and they haven't had a bowel movement in several days, I'm going to probably call the doctor and ask for something for constipation. So that portion of the lecture concludes the elimination portion of what is on our final. I'm going to go ahead and end this recording here, and hopefully it goes through and we don't have any issues with upload, and then I'll go ahead and record the other concepts that'll be on our final.